Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Each episode that we are doing is dissecting a real clinical case from a runner.
We're breaking it down from every angle: injuries, biomechanics, training, hormones, mindset, and more.
It's really the interdisciplinary approach that we wish every runner had access to.
So whether you're a clinician, a coach, or a runner yourself, you'll walk away with real-world strategies, expert interdisciplinary insights, and maybe even a few aha moments.
This is Interdisciplinary Case Miles.
Real runners, real problems, real solutions.
And this is available anywhere you get your podcast. Subscribe now and join us case by case, stride by stride. Hey everyone, welcome to Interdisciplinary Case Miles. And we are very excited to be back and present the case that we have today. How you doing, Kelsey? How you doing, Sarah?
Doing good. Good to see you guys. A little sad it's through a screen. We were just all together, a week or I don't even remember how long ago it was, but
but good to kick off a Monday with you guys.
Yeah, that's right. It is Monday, isn't it? Ooh, it's been one of those days, actually. I don't know about you guys, but I feel like I had whatever I thought I was going to do today is not what I've done.
I'm with you on that.
Well, at least we made it here.
Yes.
Hi, everybody. I am super excited to announce that we officially have our first sponsor for our podcast. And Sarah, Kelsey, and I are super excited because we haven't even released our podcast. So this is somebody who really believes in what we're doing. So this is Lever Movement Systems. And I'm also excited, which I've said 3 times already, but because I use this with my patients a lot. So this system is a body weight system where we can offload the body if somebody has a tendinopathy or a bone stress injury, or they're coming back to running postpartum. So there are a lot of different ways that we can use this system and that we use it in our clinic. And I really want you guys, if you've never checked them out before, I would love for you to check them out on levermovement.com because they are believing in us and they're allowing us to bring these cases to you. And so because they're believing in us and allowing us to do what we love, I would love for you to support them. Okay, so this case, we're just going to dive right in because we want these podcasts to not go too long so that people can hear them bite-sized. But this is a case that we're all really excited about presenting because there are a lot of different complicating factors that go into this case. But we're going to talk about a 33-year-old professional marathon runner who just had her first child. She had a C-section and she had a small diastasis recti. So if you don't know what that is, that's the split in the abs. And that's normal during pregnancy and postpartum. But it does, in most people, come back together. Sometimes you need to have care to help that along. This athlete was breastfeeding and she was under the care of like a collaborative team where there was coaching and physicians and PTs involved in the beginning of her care, and she was treated and kind of coached through what to do during pregnancy and then to that postpartum point. So I just kind of wanted to clear that up. Is there anything else you want to add for just the setup of the case?
I think that's great.
Okay, Good. Then I will start with, I was the first person to actually see this person. This athlete actually presented to PT 5 weeks postpartum, which was perfect for us. And I had coached her previously, and like as a team, the team that was working with this athlete had coached her to go see a pelvic health therapist right around that kind of 3 or 4 week mark. I'm not a pelvic health therapist, so I don't do internal work. So we wanted to make sure somebody had done that piece. It's really important postpartum for any athlete. So she was under the care of a pelvic health therapist, but then she saw me 5 weeks postpartum. And at that appointment, we kind of set up what her care was going to look like as she returned to sport. One of the things to note is that everybody who returns to running postpartum is different, and their return to run program is going to be different. Their care is going to be different. All of that based on their life, their symptoms, their goals, and everything else. So really, you just never know what it's going to look like, but it's important to have a plan. So our first few appointments were all about figuring out how to breathe, like how to use the diaphragm, making sure the C-section scar was moving. So doing some deep friction on the C-section scar, make sure it was healing appropriately. We started doing deep core work, thinking about stability and mobility of her ankles and her hips, as well as her pelvis and her pelvic girdle. We also did a bunch of foot and ankle stability. So looking at that arch of the foot, making sure that she can maintain that. And also some neural mobility, so just how the nerves move within the body. We've talked about that in another case before. So that's kind of what we started with in terms of like our first couple of visits. And through that time, we worked up over several months to increasing her walk to run. When she came to me at 5 weeks, she was walking every single day, 30 to 45 minutes with a stroller, which is a lot at 5 weeks. I was not in control of her actual return to run program. And that was something that I think I wish I had had a little bit more control over because it was really fast. So I'm going to kind of stop there and say that I would, other than that piece, her sleeping was not great. And I think that when we all kind of, when we get a little bit further, we'll talk about how important that is. But her sleeping was never really great. The return to run was pretty quick. And again, it can be sometimes with professional athletes, depending on the support that they have. Sometimes it's too quick, sometimes it's not quick enough, right? But we really didn't have control over that piece. So I think that's where we'll start. Sara, do you want to jump in on this case first and talk a little bit about the return, like just what you're looking for in somebody who's coming back, especially a professional athlete when they're returning to run after having a baby?
Yeah, so I think a few things in this case. I think that one of the biggest things that you brought up is just that every case is so different, and there's so many different factors. I think the stress piece, the sleep, no one's going to be sleeping well at this point, especially those folks who are breastfeeding. So, you've had so many things, the athletes had so many things happen to their body, all the hormone changes, and the body is actually different after pregnancy than when it was coming into pregnancy. And I think sometimes there's also the mental health standpoint of we need to make some acknowledgement that some things are going to be different and we need to accommodate that and not fight it. So I think a lot of it's kind of setting the scene exactly like what you said, Kate. I think a few of the things I think about from the physician standpoint is specifically the delivery. So was there any kind of trauma that happened? How long were they, if they had a C-section, did they spend some time pushing? Did they spend some time laboring? Was baby in distress at some point, and ultimately what was the outcome, and how does the patient feel like her progress has gone? Does she feel like she's ready to run, or does she feel like things are just really still kind of trudging through the mud and not doing so well? So I think a lot of that is really kind of setting the scene and figuring out where are we at this point. I also like to look back at where they were prior to.
Yes.
So Yeah. So are there bone stress injury histories already? Or do they already have some tendinopathy issues? Have we looked at their gait before they before they were pregnant? So before they started having any kind of laxity changes or, weight changes that can potentially affect their gait. So being able to maybe compare back to that, I think can be very helpful too. I love asking history of injury because it gives you so much information. It can tell you where they are potentially on that red spectrum. So have they had some signals of low energy availability in the past? And then also might also tell you what their run gait looks like. So do they have IT band issues and, kind of the whole gamut of certain gait patterns that give you some suggestion they may have some weaknesses that we may want to target. But then they might also have new weaknesses they've never had before simply because they went through a pregnancy that their body hasn't experienced before. So those are a lot of the things that I'm looking at. Then, of course, are they on new medications? Did they have a surgery related to the delivery or afterwards? Did they have tearing? Do they have any pelvic symptoms? So any pelvic floor symptoms like urinary incontinence? One of the things I always like to mention on anytime we're having these type of conversations is that I have patients who tell me, oh, I have urinary incontinence, anytime I sneeze or cough, but that's just the way it is. And I say, well, it's common, but it's not normal. So it's always something that we can address. And I really think I really try to enforce that with patients that tell your healthcare provider, these are things that we can work on. So just because something's common doesn't mean we can't potentially address it.
That is actually my most favorite thing to say about stress urinary incontinence. When I wrote that book about returning to run pregnancy postpartum, the person I wrote it with, who's a pelvic health therapist, told me that, and it was like mind blowing to me at the time because it's so true. I would like to point out for this case before Kelsey jumps in is that this athlete did have a history of stress fractures, did have a history of tendinopathy that was being managed and kind of cleared up a little bit during pregnancy as she continued to run. But it was always there in the background. So I think it's important to know that. And everything that you said, yes, we have to ask all those questions. And we do too.
Yeah. Well, and one thing I was going to add too is if I recall, I believe she had a bone stress injury that was most concerning for REDS. So trabecular rich bone stress injury, and really hadn't had a workup. From the nutritional standpoint of that, which I think is really important to consider because it suggests there may have been a nutritional issue even prior to pregnancy and postpartum.
Yes. And Kelsey, what I would like to know from this point, and just from not particularly this case, but if you were to see an athlete like this in the beginning, because this is not somebody that you had known at the time in the beginning, what would some of those things that you would tell this athlete right when they were first postpartum to do so that they could put themselves and set themselves up for decreased risk for injury and also better performance as they start to train?
Great question. And I had a brand new client this morning that's 7 weeks postpartum.
Ooh.
And yeah, so I got a lot of practice earlier today. So a big question would be, are they planning to breastfeed? Because that will mimic the third trimester of pregnancy in terms of calorie needs. We do have some newer recommendations for protein while we're breastfeeding too. That's a little bit higher than when we're just running. So I would go through protein requirements and current intake. Fluid requirements is really big, especially when I think about hydration and putting them or decreasing the risk of tendinopathies with proper hydration. Also, this is so cool. I love talking about this because survival says that the baby will get all of the nutrients through that the mom is consuming. And so in the event that the mom isn't consuming enough iron, calcium, those kinds of micronutrients specific to bone, if we're not consuming enough for mom and baby, then calcium from the bone can be leached from the mom because the baby's going to get priority. And so that's a big thing that I did today was assess how much calcium are we taking in. And not with this case, but with this specific case we're talking about, but with my client this morning, and talk about how else can we get calcium into the diet, look at vitamin D levels to make sure we're absorbing the calcium that we are taking. And yeah, I think the biggest thing is if we are consuming more calories, we have a greater opportunity to get in these other micronutrients that we need because baby will take if we're not getting enough for both parties.
That's right. And I think that another comment that I think people should understand is that we need at least, isn't it, 500 calories. At least this is what the research used to say. If you're breastfeeding and exercising, or if you're just breastfeeding, you need to have at least an additional 500 calories or something like that.
Yeah, I like a range a lot. I'll say anything from 450 to 600 because you have to think too, like when baby goes through growth spurt, like you both, you can kind of feel that you are breastfeeding more, or even the composition of the breast milk and that kind of thing can put different nutritional demands on the mom.
That's great. That's really good advice, because that number was something that was in research that everyone was saying 500, 500, 500. But I think that brings up the point again, is that everybody is individual. Their needs, the child's needs, what this all looks like when we put it together.
Yeah, and it can be a little tricky because how do you plan for that? Your baby's going to go through a growth spurt this week.
You
So
don't.
just being flexible.
That's right. Okay, great. And so that was kind of where we were looking at the beginning. Now, this case that we're talking about is a really long case. So this is over months and actually more than a year. So we're going to kind of fast forward and just say that during this year postpartum, that's where we started. Those were the things that we were really looking at. And this athlete did everything that we asked. I will say that. The strength training, the mobility. We did run gait analysis on multiple occasions. And then we did some form adjustments, because that's all part of what we do when we see an athlete. She met with the physician. She met with, we were looking at all of these things all along, but something wasn't right. And this comes down to a discussion that we had prior to this podcast about kind of sometimes what happens when, I don't know, how do you want to say it, Kelsey?
No, I think that, in people that become coaches and even parents of great athletes, sometimes they have their own athletic accolades. And so there is a level of bias that comes in where there's experiences they have that are super valuable. And then there's the experience of, well, I did it this way and I had athletic success. So it's easy for them to be biased about how something needs to be done.
Yes. And so what happens a lot of times is they put those values and beliefs and experiences on the athlete that they're coaching. And that can be really, really hard for the athlete. And it can be really hard for the medical team, because we want to respect the coaches and their knowledge and everything that they're doing and their relationship with the athlete, while doing what's best for the athlete at the same time.
Yeah. So I was actually going to throw another piece in. So, I think another piece of how an interdisciplinary team can be so helpful, especially when there's some kind of contact with the coaching side. So oftentimes coaches, psychologists, the folks who are either have some privileged information and or are not officially part of the medical team. Oftentimes we have to get one-sided information. So we can't necessarily give information that we've gotten from a HIPAA standpoint, privacy standpoint, but they can give us their input. And so I think I think it's really important to think about what the coach is saying. So when coaches comes and says, hey, this athlete's just underperforming, and to your point of, I'm treating him just like I would anyone who had gone postpartum. We're doing all the things, but things just aren't right. And so here's some of the things that are happening. And I found that very valuable in cases like this, where we're hearing it from all sides. So how the athlete's feeling, how what the coach's experience on their side as well, and how can we kind of put these things together to figure out how we can improve what's happening. The other piece is having a psychologist involved, where we can give them our information on our side of, hey, this is what's going on. This is what we're worried about, And so if the psychologist is meeting with the athlete, then they have the concerns of the medical team kind of in the back of their mind as well. And so I think all those other providers are so, so valuable in this type of scenario, where I was mentioning earlier that there are so many grays when it comes to relative energy deficiency and being postpartum and dealing with mental health and mindset and sports identity, all these pieces. There is no one size fits all. And so we have to take all these different pieces together and figure out how we're going to move everyone forward. And this has got to happen in the environment of an interdisciplinary team. I think is the best place for it to happen.
Yeah, I think so too. And a point that you just brought up, which is really kind of where we're going with this, is REDS, so relative energy deficiency in sport, or low energy availability, doesn't always show up in the same way. And this athlete did struggle with, calf tightness and some posterior tib issues after, while, that whole year kind of as training increased and, more mileage and racing and all that. So those things were there, and there were definitely some clues along the way in terms of not having enough sleep, maybe not. But the biggest thing that came up was bonking and underperforming and not really performing in the way that she felt like she could because she was doing everything else right. So she was doing the strength. She was doing all of the things that we were asking her. So then it showed up in this place of performance. And Kelsey, why don't you speak to that a little bit? Because this is where you get really, this is your good stuff.
Yeah, I think when you're having an athlete that's having trouble bonking, obviously you want to find out why, and why this case is different from just the occasional, like, oh, are we meeting the carbohydrate needs per hour and that kind of thing? Because she was, to your point, like doing all of the things of these are the carbohydrate recommendations during activity per hour. She was doing that. She was eating pre-run. She was doing everything that on a basic level. But I think that, to Sarah's point of how do we even, every case is different. How do we even know what her needs were? Because she jumped right back into training after postpartum, what her nutrition needs were when she was breastfeeding and marathon training at a professional level, without the guidance of a dietitian at that time. I think that we couldn't have overestimated her nutrition needs at that point, healing pelvic floor, that kind of thing. And so, with someone that is bonking, and in this situation, the way that I approached it was thinking about the short term, like how can we get her to feel better in the short term? But really, the bonking was coming from, and I'm inferring, but I think it's fair. With red, sometimes we do see, just like we get suppressed hormones such as estrogen and progesterone that influence whether or not we get a cycle. The other hormones are also suppressed. And these hormones include ones that regulate blood sugar metabolism. And so just to name a few, insulin and glucagon. And so we're not normally checking in a lab setting for those hormones, but this athlete specifically had a hard time keeping her blood sugar levels like relatively stable. They don't have to be the same thing during activity consistently, but there was enough fluctuation for her to be symptomatic. And that despite eating before she ran, and despite trying to change the formulas that she was using during, even the type of carbohydrate and the amount, that she was still bonking. And I really do think that it came from a place of, and we're starting to see this more so be represented in the science, that these blood sugar markers were influenced by the relative energy deficiency in sport.
And the thing that I always find so challenging to talk to patients about with all this is exactly what you described. These are hormone suppression systems, and this is not something that happened last night. This has been going on for a long time. And actually, in this case, probably she was already in this state before she was even pregnant, and then had pregnancy, and then postpartum and lactation, and trying to get back with the additional stresses of not sleeping, all these other things. And so I think having these conversations of, we're talking on the order of months to years to be able to manage all of this, and also being able to set those expectations. Because I think sometimes athletes can feel like, oh, this is all my fault. Like, I ate right today. I must have done something wrong. And the answer is, you're doing it right now, but it's going to take time for these things to recover. And that, it's the hardest thing, I think, to hear. But I have these conversations so frequently in clinic, and the same goes when folks have low bone density and we're in these scenarios. It takes so long to recover all these different hormone systems and get them back to normalcy and get bone density back up. And it can be very frustrating.
Yeah, and just for context, outside of the context of pregnancy per se, I've had other cases where we've been able to restore someone's menstrual cycle before we've been able to positively influence their blood sugar metabolism. That's how long that specific trait can kind of take and to recover.
And I think it's worth mentioning that after you have a baby, you don't get your cycle for quite a long time. So when people use their cycle as a marker of whether or not they're eating enough, that's already a problem. The cycle is like one of those last things to go, or one in the later part of low energy availability in REDS, but a lot of people don't realize that. And so that becomes the marker that's, oh, I've lost my period. Either one, that's great because that's what culture says. It means I'm training hard enough, which we all know is not true, but that is or has been a topic of conversation for women for a long time in coaching. But also, two, when you lose your period, that's when you have to do something. Again, that's not right either because we're way too far down that path if we've lost our cycle. But then to complicate it further, if you're postpartum and you're not getting a cycle anyway, there might not be that kind of cue for people to pay attention in the way that we want them to. And again, we should be paying attention way before that happens. But unfortunately, that's when people sometimes show up.
Yeah. And so in this case, we had to, think about the short term of like food pairing, pre-run, and changing formulas and that kind of thing. But I really do think that it was helping this athlete to see the long game, that it was going to be the recovery of these hormones. And then I did want to mention too, we had access, it was when they were newer on the market for general population, we did have a continuous glucose monitor, but because it was kind of early days of this being used with an athletic population, even interpreting that information, and this athlete, because they were a professional athlete, had like a whole healthcare team to help interpret that data. And so just another, these gadgets are really, really popular, but even having it takes experts to be able to interpret data correctly, because I've had other athletes using this information in the wild, and they're seeing the change in blood sugar to be a negative thing, and it is normal for your blood sugar to change.
I like that call out right there, Kelsey. I think
Thank you. I feel better now.
as you should. I think it's an important thing because you're right. Like, and I love how you said in the wild. I would also like to mention that because it's true. I mean, there's so much information available to us now and so many tools available to everybody. But just because you have the tool doesn't mean you understand how to interpret the information, or that you should interpret it a certain way. Everybody is individual. So just because one person's blood glucose monitor says this and they need to do X, Y, and Z does not mean that if yours says that, you need to do the same thing, which is really what we're talking about here in terms of like every case is so individual. So experience is great. And
yeah, it's like when I get a set of labs and they all come back as normal. And so my athlete writes it off and thinks everything's fine. I'm like, actually, I'm looking at everything in context and kind of within certain ranges. And so your ferritin might actually be low for an aerobic athlete, especially one that might be going to altitude, or thyroid hormones could be on the lower side that make it suspicious for low energy availability. So everything is in context. And exactly what you're saying. I had a conversation with a young runner the other day, and they had a blood glucose of 62 mid-morning. And I was like, well, technically that's kind of normal, but like you should have already had breakfast and you should have been a little bit higher than this. And they're like, well, I didn't eat breakfast. I'm like, well, bingo. We need to eat some breakfast. So it stimulated a lot of conversation. And sure, 62, we can live with that. That's not a problem. But it gives me clues that things may not be quite where they need to be. And so, like I said, everything is very much contextual. Exactly what you're saying. You see blood sugars going up and down. Oh, no, we got to control everything. But no, that's what they're supposed to do. We've got feedback mechanisms for all of this.
And controlling everything often leads to so many other issues, right? Because it's not reality. We can't control everything, but it can impact our ability to think clearly, and it can make us really stressed out because a lot of athletes have a difficult time with not being able to control everything. Okay, so ladies, let's talk about this. Is there anything else that we think people should know about in terms of when they have this kind of this is an atypical case, but in one way, but in another, it's a very typical case. Lots of women have babies. Lots of women go back to running pretty quickly. And there's a lot of people that breastfeed. Some of them are going to sign up for marathons. So what is it about this case that we really want to make sure people know? And Sara, I'm going to let you go first, and then Kelsey.
Yeah, I think a couple of things. The most important being that every case is individualized. Use your resources, work with folks who understand postpartum care, pelvic floor, dietitian. This stuff is hard, and especially when you're adding high volume activity, it is so easy to get behind, even for the folks who aren't doing a lot of activity. But once you start adding more and more, especially a marathoner's volume, it's hard to do. It's hard to stay on top of all these things. So use expert advice. I had one more point, and it just slipped my mind.
Well, if you think about it, we can come back to you.
Okay.
Okay. Go ahead, Kelsey.
As we were talking, I was trying to figure out in my head, would we classify this case as intentional or unintentional underfueling? And so some of the things that Sara brought up of, how society puts pressure on moms to bounce back, whatever the heck that means. So maybe there was some subconscious intentional underfueling, but also there, breastfeeding is something that I would consider hypermetabolic. So, the needs were just really high. And so that would fall into the unintentional. So there can be both, right? Existing at the same time of just not being able to quantify the stressors of being a new mom and lactating and trying to get back to marathoning at a higher level at a different stage of your life than you ever have. And then also there can be a quiet voice in your head of, oh, well, you need to get back and ASAP. And what do you need to do to for control again? So I think that this case kind of falls beautifully into both categories.
Yeah. And I think that for me, there's a couple of things that really stick out. Something I like to say is postpartum is forever. So this case is a long case. So this is happening over years, months. And just because you had a baby a year ago or a year and a half ago or 2 years ago, you might still be in that kind of category, depending on if you're still breastfeeding or if things haven't cleared up or if you're, having things happen metabolically. So I think that if you're somebody who had a baby, 6 months or a year ago and you're thinking, great, I'm not postpartum anymore. Well, that's not true. And our body changes. If we're just looking from a PT standpoint, biomechanically, functionally, our body is different. Our feet change, the position of our hips change. Sometimes they stay bigger. Sometimes they don't. Sometimes our feet flatten out. Sometimes they don't. There are all these different things. A lot of times posture changes, which changes the way that we move and we run in our run gait. So it changes our arm swing, how our hips are, and how our foot lands. So there are so many different pieces of this that we have to think about. And most people think about the stuff that I deal with, right? Like the physical stuff. I'm going to get back from having a baby and I'm going to go do strength training and I'm going to get strong again. And I'm going to look at my biomechanics. And while all this is very important, obviously it's my job. What you guys are talking about in terms of food and sleep and stress and, hormones is just as, or sometimes even more important, but maybe not thought about.
Yeah, and the other piece I was going to add is it's so important to encourage all athletes, but especially postpartum, that you're getting to know a brand new body. And I think that it's even more important to be really mindful of the times that bodies need rest. So having the coach that sends the athlete home and they're like, no, you're not ready for workout today, go rest. And doing it in a positive way, not a way that sounds like, oh, you didn't do the right things, but more of acknowledging that your body's going through a lot. And sometimes we need rest, and that's more important than having a hard workout. Because if you can't recover from the hard workout's worthless. So having that support system that really gets it and really training that mindfulness. I mean, you can do that anytime. But it's so valuable, I think, in that postpartum time. The more stress you have in your life, regardless of what it is, the more important I think that piece is to really be able to look inside yourself and understand what your body needs.
Yeah, and you're talking about community too, right? So having a community of support around you, whether it's other women in the same space or women that maybe have gone through it before, or healthcare providers or coaches or whoever is on your side so that you can be supported. And the other thing I see a lot is injuries happen postpartum. I find that if women go slower in the beginning, even though we're itching to get back, look, I am a woman that had a baby and pushed myself too hard, even though I knew better, and ended up in a boot at like week 7 postpartum because I did too much. So I just want to put that out there and let everyone know that nobody is perfect, including someone who knows what to do. I couldn't reconcile my clinical knowledge with my need for speed.
That cognitive dissonance will get you every time.
It gets you. And so I want to say, like, hey, it's okay if it happens, but know that there are support systems. And if you start slower and you build yourself back up in all of these ways, you're less likely to end up in our clinics injured if you take it slow on the front end. So all those athletes that, take a little bit more time, whether it's 2 or 3 months or even 4 months to kind of get, quote, back to running, that's okay, because it's very possible you won't end up in our clinic by doing that. But I really do get the need for speed or just a mental break, whether even if it's not fast, you're just out there doing the motion. Yeah. All right, ladies. Well, I think that's good. This is actually a really fun case. And I think we touched upon a lot of really important things from all of our disciplines and even outside of our disciplines a little bit. Anything else you want to add before we sign off?
Well, I was going to say, Kate, just to prove the cognitive dissonance, I haven't told Kate this yet, but the text that I sent you earlier about that theoretical case is actually me. So.
Oh, the theoretical case that you were sending me in text message? Oh God, girl, I'll fix you up. I'll write that. Oh geez, that's really funny. Okay, so maybe let's just give some context real quick. I got these, I won't read them, but I do have my phone here. I got all these text messages today about a possible patient that was, sorry, a possible patient.
Return to run program.
I wanted a general return to run program. And then I started asking all of these questions about, well, what do you mean by general? And how much have they been doing? And like asking all these questions. And then I didn't get any answer after a while. And I was wondering, like, well, maybe she's in her meeting now or in clinic. Okay, Sarah, we'll talk later.
I was about to say, did you not pick up hints either?
Well, also, she does text me like this throughout the day. Like we all text each other random things throughout the day about like helping each other out with patients. So I was really truly assuming it was a patient.
Pretty great.
And I thought she was in the room with a patient, because then when it stopped, I was like, oh, she's not with that patient anymore. We'll talk about it later.
I was trying to figure out exactly how I was going to break it to you that this is not just a theoretical patient of mine.
Well, I'm glad you did it on the pod. I'll be sure to call you later. All right. Well, let's wrap this up. And I wanted to say that we do have an email, and the email is runkasemiles@gmail.com. So if people want to submit cases to us for us to go over, we have a spreadsheet going of a whole bunch of different cases, and it can be female athlete or not. We do have cases that are also male athletes. We just haven't done one yet. So if you have a case and you want us to go over, if you have any questions, feel free to email us at that runcasemiles@gmail.com. And make sure to follow our podcast and share it with people, because the way that this grows and the way that we can actually make a big impact in athletes' lives is if they know about us. So share it with everybody you know, and ask us any questions, and we're happy to help, and we're just excited to be here. That's all I got, guys.